Okay, so anybody can respond? What are the possible inguinal swellings?
Hernia.
Hernia, very good. What else? Anybody else?
Maybe
Salivary
tumors.
gland.
In the inguinal region, what are the possible swellings?
Enlarge in the lymph node.
Enlarged lymph node, very good. What else?
Arterial aneurysm.
Abscess,
Arterial aneurysm, very good.
abscess,
Abscess, very good. Okay, so if
and
you talk
descent.
about, very good. So if you see different structures, first of all you talked about hernias. So hernias can be two types, either inguinal hernia or femoral. So do you know anything about inguinal hernias?
Yes, about its
Yes,
location.
direct and indirect inguinal hernia.
Very good. Indirect inguinal hernia. So if you see the area, this area, this is the abdomen. Here is the scrotum in male. Here is the superficial inguinal ring, and here is the deep ring. So from the deep ring, the spermatic cord and other structures, they come here into the scrotum up to the testes. So this is known as deep inguinal ring, and this is known as superficial inguinal ring. If the hernia comes through the deep ring, it comes like this, the sac, and then the gut in it. This is known as which hernia, direct or indirect?
Direct.
Indirect.
This is known as indirect hernia, very good. But if the hernia comes through this space, lateral to the deep inguinal ring, this is known as direct inguinal hernia. And these hernias are above the inguinal ligament usually. So the most important thing about any hernia is reducibility. Please remember this word, to be reducible. I'm sorry. So we have direct and we have indirect. Sometimes the hernia can be from this area, which is the femoral canal here, and there is a femoral ring. So hernia through the femoral ring is known as femoral hernia. This is infrainguinal hernia. This is a bit below. So if there is a hernia, the most important thing you need to remember is it is reducible. So suppose I say a 15 years old male patient presented with inguinal swelling for the last 2 years. 2 years back, it was disappearing on lying down and appearing on standing. So now I have described the word reducibility. Is this point clear to everybody?
Yes.
No, doctor, can you
Yes.
repeat it?
Was there a comment from the female side?
Yes, doctor, I don't get it.
So if I say there is a 25 years old male and now he has presented, this is the umbilicus, he has presented with a swelling in his right or left groin. This is the swelling. It is there for the last 1 year. Okay. Now it means it is not reducible now. It is not reducing. But 2 years back, patient noticed this swelling while uh, suppose walking or lifting heavy objects. So what happened by walking, lifting heavy objects or anything? There was an increase in the intra-abdominal pressure. This caused the swelling to come out from this deep inguinal or the direct hernia. So this is the appearance of the swelling. But the moment patient lies supine, in the beginning it will go back. It will go back, or we can say the swelling disappear by itself. Or later on the patient will tell us, I am able to push it back in the abdomen. So this concept is known as reducibility. If such a concept is there in any swelling, you should know that you are talking about a hernia. So this is the concept of reducibility, that it appears on increase in intra-abdominal pressure, but it disappears once a person is lying down in the bed or he is supine. So this concept is known as reducibility. Is it clear or still not?
Yes, doctor. Thank you.
Okay, now suppose the patient is having a swelling here and we have a pubic tubercle here on both sides. If the swelling in the groin is above and medial to the pubic tubercle, it is not reducible. Then it is known as inguinal hernia, probably. But if it is below and lateral, then this hernia is femoral hernia. So if there is a groin of this patient and here is the pubic tubercle, if the swelling is above and medial here, then this is most probably inguinal hernia. But if it is below and lateral here, this is femoral hernia. Just to remind you, which hernia is more common in male, in females? Which hernia is more common in female patients? Inguinal hernia,
Femoral
femoral
hernia.
hernia.
Inguinal
Femoral
hernia.
Femoral.
Femoral hernia more common in female more than male,
Yeah.
but as general, inguinal hernia common in male and female.
Very good. So inguinal
Yes.
hernia is more common in females. Inguinal hernia is more common. But if I change my question, femoral hernia is more common in male or female?
Female.
Now it's female. So please do not confuse this point, because sometimes this is important. If I ask you which hernia, inguinal versus femoral, which hernia is more dangerous?
Femoral.
Answer is true. Why?
Because it have a small neck, so there is increase in strangulation.
Yeah, because the opening of the femoral ring, 1.25 centimeter to 2.5, it is very small. If the gut comes out of this opening, then it may not be able to go back, and there is a risk of strangulation, obstruction, and so every femoral hernia should be promptly treated. Anyway, so once you have a reducible swelling, the diagnosis is hernia. Step 1. Step 2. Swelling is above and
Inguinal.
inguinal hernia. Swelling is below and lateral to pubic tubercle. Femoral hernia. Clear? Step 3. Now you decided it is inguinal hernia. Clear? You ask the patient to flex his thigh and leg at a hip joint and elbow joint, and ask the patient to reduce it. It will disappear and go into the abdomen. Clear? After this is the pubic symphysis. Here is the pubic tubercle. There is the deep ring. So you will measure this distance from here to here. It is supposed 12 centimeter. This is the deep ring. Here is the pubic tubercle. So you measure this distance. It is supposed 12 centimeters. So at 6 centimeter, 1.25 centimeter above, you will put your finger or thumb and ask the patient to cough. So by putting a thumb over here, you are going to occlude which opening?
Deep inguinal ring.
Very good. Deep inguinal ring. So the deep ring is closed. Now if there is a hernia which was coming from in between the deep ring and this pubic tubercle, if it appears, then it will be which hernia?
Indirect.
No, I mean, look, this is the pubic symphysis, pubic tubercle, and this is the deep ring. This is anterior superior iliac spine, sorry. This is the deep ring in the middle of the anterior superior iliac spine and pubic tubercle. So 1.25 centimeter above, you put your thumb or any pressure over here and ask the patient to cough. If the hernia was coming through the deep ring, we call it indirect inguinal hernia. Agreed?
Yes.
Yeah, I agree.
If you close this ring, will it appear? No, it will not appear. So we will say the ring occlusion test is positive and the patient was having indirect inguinal hernia. Clear? But if you put your thumb over here or finger and ask the patient to cough, but still there is a swelling in this area, it means this hernia is not direct inguinal hernia. It is direct inguinal hernia. So number one, step A, you look for reducibility. This will tell you with hernia. Then you see its relation with the pubic tubercle. If it is below and lateral to the pubic tubercle, it is femoral hernia. So no problem about femoral hernia, direct or indirect. But if it is above and medial to the pubic tubercle, it is inguinal hernia. To decide that the inguinal hernia is direct or indirect, what we will do? We will perform ring occlusion test. So which ring we are talking about? Deep ring, very good. So we will close the deep ring. So how we will close? This is the anterior superior iliac spine. Here is the pubic tubercle. We will measure the distance in the middle. Just above that, there is a deep ring. If we put the tip of our thumb or finger and then ask the patient to cough, if nothing appears, this is indirect inguinal hernia patient. If a swelling appears, this is direct inguinal hernia. Am I clear up to this point?
Clear.
Anybody who has in any inquiry, if he or she wants, I can repeat it. Okay, I think everybody got it. So now let us go to the next step. So the patient has presented to you with the groin swelling. Initially it was reducible. Please remember the indirect inguinal hernia. It is you. Anybody knows how the testis descends in male or ovary descends in females?
Yes, doctor.
Yeah,
From
please go ahead.
okay, from the abdominal wall, and then go to the deep ring, then inguinal canal, then superficial ring, and then scrotum.
So in the fetal life, the kidneys and then the testes, they develop from the back of the thorax. This is the reason the testicular artery that arises from the aorta and direct then comes to the this way. So this reminds us the origin of the testicles from the posterior abdominal wall. So the testicular artery follows the same passage. But the testicles, once they come at this point at the deep ring, in infants, the superficial and deep ring are overlying each other. There is no inguinal canal in at birth. Anyway, so then once the testes come over here, then they take a part or pouch of peritoneum with them in the scrotum. So this peritoneum, suppose it is lying like this, then from this peritoneum the testes will come and it will take it to like this. This testes will move down in the scrotum with a part of peritoneum with it. This is known as processus vaginalis. So indirect inguinal hernia is actually patent processus vaginalis, and the gut may enter through the deep ring in this processus vaginalis, and this is the reason indirect inguinal hernia is more common in young patients. In small children, almost always it is the indirect inguinal hernia, but in the older age people, 40 plus, maybe before that, if they are workers, then it is direct.
Yeah.
So please understand this difference. Now this patient who is having a groin swelling for the last 1 year, he has started vomiting, abdominal pain, abdominal distension, and absolute constipation. So there is a patient, he has all these features of the groin swelling, and now it is vomiting, pain, distension, and constipation. So what are these four features indicating?
Obstruction.
Intestinal obstruction. If the patient is having a hernia and now there are features of intestinal obstruction, what is our diagnosis? Obstructed inguinal hernia. So now, number one, you should be able to diagnose hernia, to decide it is femoral or inguinal, to decide if it is inguinal direct or indirect, and then to decide the hernia is reducible, irreducible, or obstructed. Then is the strangulated. In the strangulated hernia, here the pain is in the abdomen, colicky. But once it is strangulated, this pain is colicky, it is due to peristalsis of the gut to overcome the obstruction. Clear? But in strangulation, it is pain of ischemia. It is not severe pain in the hernia, then we call it strangulated hernia. Or So these are the learning points till now we have discussed. If there is any confusion, you can ask me, otherwise I will continue. The second most important thing here is the lymph nodes in the groin. So there is the deep ring, then there is the femoral ring, and then we have the direct hernia. So these are the hernia part. Now we are talking about lymph node. There is a 25-year-old blackening of his toe, and now he has hard, shorty swelling in his groin. Anybody who can comment on this? So a young male, there is a blackening of the toe for the last 6 months or so, and now hard, shorty swelling. So these are the lymph node. So actually, this is a case of subungual melanoma, and this is indicating hard, shorty swelling in the groin is indicating the
Metastasis.
malignant lymph node, malignant lymph nodes, the melanoma cells from the, this is suppose the foot, and this here is the groin. So from here, the melanoma cells, they have gone through lymphatics in the groin. So this is the groin. So from the foot, the lymphatic cells has come here in the lymph nodes. There is superficial, deep, different definitions. I will not go into details. But in carcinomas, the lymph nodes will be hard, non-tender. Clear? Now there is another patient, diabetic foot, 78 years male, like you have seen a patient in the ward, and there is an ulcer, and patient is having high grade fever, and there is pus coming out of the wound. So in this patient now there is tender 2 to 2 centimeter swellings in the patient groin. So now it is painful swellings in the groin. Again, these are the lymph nodes, but now because they are because of infection, so they are painful. So we have discussed the inguinal, the hernias. We have discussed the lymph nodes. Lymph node enlargement can be due to the infection. Then they will be painful, tender, or then the other possibility is that this is enlargement is due to malignancy. Then they will be hard, non-tender. These infection lymph nodes, they will have the microorganisms. So it is possible that this lymph node which is infected, it becomes now suppurative. That is, there is a pus formation in the lymph node because the microorganisms are coming through the lymphatics to the lymph nodes. So this lymph node, after pus formation, it will become an abscess. So the lymph node infection by the microorganisms coming through the lymphatics, this can present as lymphadenitis, lymphadenitis. It means inflammation of the lymph node. But if there is a pus formation, then it becomes abscess. And I have told you it can be due to malignancy, like I have given you example of the melanoma, or it can be due to the infection. There are other causes like its own malignancy, lymphomas, and other situations. But for the time being, my target is that you learn that the lymph nodes can get enlarged in malignancy or in infection. Is this point clear to everybody?
Yes, doctor.
If somebody wants to ask, please do not hesitate. Okay, so I have talked about now hernias. I have talked about the lymph node. The other structure in the groin is this is the groin. So here we have the artery, which is called femoral artery. Now, what can be the problem which can make a swelling of this femoral artery? So sometimes, like suppose there is a patient, 67 years old male, he has chest pain, blah blah. Like this patient, our diabetic patient today, the students, male and females, they have seen one patient. I think four, room 6 or something. There is a patient who's dressing and other things, and Doppler was done in front of students. So that patient, he is planned for angiography. Now they can do angiography. How they will do angiography? Does anybody has an idea?
Because it's maybe aneurysm. There is aneurysm in the artery.
Through the
They have to reach the coronary vessels. They have to reach the coronary vessels in the heart. So they will go directly through the chest.
No, they will go from through the femoral artery.
Excellent. They can go through the femoral artery or the radial artery. So from here, so the side from where they enter the vessel, so they will go and then they will put a contrast and take a picture, and this is known as angiography. But from where they put the needle, this can cause weakness of the artery, and you know there is a lot of pressure. So this pressure inside the vessel may give rise to dilatation of the arterial wall, pseudo aneurysm. Clear? So if I say a 67 years old male presented with a groin swelling, there is a history of PCI 5 years back. So how I will link these two swellings, that the PCI may have been performed through the femoral artery, and now due to the weakness of the needle introduction point, there is a possibility of the pseudo aneurysm. Other possibility, so other thing on clinical examination, if I compress an artery, if I put pressure on artery, it will be pressed or not? What do you think? If
Pressed.
pressed, so this feature is known as compressibility. So all the vascular swellings, they are compressible. So either it is artery or vein, they are compressible. What is hernia? Reducible, but the vessels are compressible. So what is the difference between compressible and reducible?
I guess
Yeah, please go ahead. Speak. Please say something. Yes, please. So it is like a spring. The moment you press it, it will be pressed. And the moment you relieve the pressure, it will bounce back. So this is known as Reducibility, and this is a feature of the vessels. But the reducibility, if you reduce it, it will stay reduced till there is an increase in the intra-abdominal pressure, and this reducibility is related to hernias. So I have given you one example. Other example for the pseudoaneurysm is that the patient is an IV abuser, IV drug abuser. So these patients usually give IV injections in their veins. Once the veins are blocked, they can give even in the arteries by themselves or by mistake, and again this will cause the vessel trauma, and this can lead to pseudoaneurysm. So these are few examples of pseudoaneurysm. So the fourth part, there is a 34 years old female. She has presented with bluish 2 into 3 centimeter infrainguinal swelling. Swelling is compressible. So what do you think? What is the diagnosis? This swelling is arterial or venous? Anybody can guess?
Vina.
Venous. So here where there is the opening of the saphenous vein into the femoral vein. So here there is a dilatation of the vein known as saphena varix. So the diagnosis is saphena varix. What investigation you will do to diagnose saphena varix? CBC is good, C-reactive protein, or duplex scan, which is best?
Duplex ultrasound.
Ultrasound. So either it is arterial problem or venous problem, we always opt for duplex scan. Like today, some students, they have seen one patient whose duplex scan was done with the arterial problem. I think bed number 3, some A, B, or C. I think C. And that patient was having genicular, I mean below the knee joint, there was narrowing of the arteries, and the patient was having gangrene of the toes. So anyway, problem is arterial or venous, you have to go for duplex scan. So we have discussed the hernias, we have discussed the lymph node problems, arterial problem, venous problem. Just one more thing, and I will stop it because we have other topics. Psoas muscle. So regarding psoas muscle, you know, psoas muscle is arising from the spine. T12, 11, 12, L1, L2, something like this. So this muscle then is inserted on the lesser trochanter of femur. Clear? This is the reason this. So if there is a tuberculosis of the spine, of the intervertebral disc, this pus will go inside the muscle and it can cause psoas muscle abscess. Because it is due to tuberculosis, so we call it cold abscess. It is not cold because it does not have the features of typical abscess, like 5 features: tubercular, hot, dollar tumor, function loss. So because it does not have the acute features, so we call it cold. Otherwise it is not cold. If you find such a patient, it will not be very much painful, but the patient, the hip joint will be flexed and he will be walking on one leg with difficulty. So this is the code. Other possibility is, suppose here there is a kidney, here there is appendix. So if there is a perinephric abscess, it can enter the psoas muscle. If there is a perforated appendix, it can enter the psoas muscle. If there is infective endocarditis, it can come to the muscle through the arteries, arterial supply. So all these things, they can cause psoas abscess. But in the acute abscess, it will be very painful and patient will not be able to extend his hip joint because the muscle will contract and it will cause flexion at hip joint. So the diagnosis will be confirmed by ultrasound. It will show you the abscess and the treatment is drainage. Of course, CBC, if you perform, the TLC count will be high. So this is about the psoas abscess. I think this much is enough because our time is limited and we have to finish other topics. Coming to the next point, what was the other topic, guys?
Melanoma.
Melanoma and I think salivary glands. So let
Salivary
us first
gland.
salivary glands and at the end I will talk about, yes, salivary glands. So we have the parotid, we have submandibular, we have sublingual and other many glands. Where is parotid gland? Does anybody remember? Parotid region, so it is in front of the ear. Very good.
Yeah.
And
Doctor,
submandibular
the
gland
screen
is,
is
you
not
know, the submandibular.
appear to us for us. You stopped sharing the screen.
I'm sharing, but maybe let me check again. Is it visible now, guys?
Yes.
Yes.
Okay, so we were talking about the salivary glands, and we have the parotid and the submandibular and the sublingual and other glands. I will talk only about the parotid and submandibular because these are the main glands. As you know, parotid is located in front of the ear, and which nerve is passing through the parotid gland?
Facial nerve.
Excellent. And you know it has 5 branches. And you should know the 5 branches. Okay, now similarly, the submandibular gland, it is related to the 3 nerves. I will discuss the 3 nerves here and 3 nerves here. But for the time being, these glands, like any other gland, they can be infected by the bacteria, viruses. The most common, the most famous virus is of the mumps
Mumps.
that can cause parotitis. And if there is parotitis, parotid gland involved, then what other structures we need to examine in the patient? If there is a parotid involvement in mumps, then we should also look for pancreas involvement. The patient abdomen should be examined and patient testes should be examined because if there is a parotitis, it can cause pancreatitis and also epidermolysis. So please just remember this point. Now, due to sometimes repeated infections, or especially in the submandibular gland, because its duct is going up, so there is a stone formation. Due to calcium and oxalate and others, this is 80% of the stones they form in the submandibular gland. And 80% are radio opaque. There may be a little difference, 75, 80, 85%, but roughly it is 80%. Now, how the patient presents? A 23 years old male patient presented to King Fahd Specialist Hospital outpatient department with complaint of recurrent submandibular swelling. Once patient is going to eat a meal, patient has pain in the submandibular area and the swelling appears. And this pain and swelling disappear Okay, what do you think?
Cyanothesis, which is a stone in the submandibular.
So this is the cyalolithiasis. The patient has a gland stone. So what happens once the patient is going to take a meal, it will trigger the formation of saliva. This saliva will go and try to open through the Warson or Stenson's duct into the oral cavity, but because there is a stone in its passage, this will cause the salivary gland to swell and painful. And gradually this saliva will trickle down from the other sides of the stone, and then the swelling and pain may disappear. So this is a typical history of a stone in the salivary gland duct. Postprandial pain and swelling is typical of salivary gland lymph node, and I told you most common site is submandibular, and 80% of the stones form in here and 80% are radio opaque. So once you suspect that the problem is in the, suppose this is the patient, this is the submandibular area, and the patient complains that there is a swelling. This is the previous history. Now swelling is not disappearing and the patient is having fever and the overlying skin is red in color and it is very painful, tender swelling. So what is the likely diagnosis?
Infectious.
Infection of the tongue? I give you the options. Suppose option A. Is my question clear?
Yes.
Doctor, can you repeat the
Acute inflammation.
I give you the options. Choose one. It is a case of SIAL, sial adenitis. It is a case of suppurated lymph node. Separated lymph node. C. It is a salivary gland abscess. Option D. It is the benign tumor.
Option A.
Salivary gland.
Salidinitis.
So as we discussed in this patient, that this patient is having a history of postprandial pain, and swelling. This indicates what? There is a salivary gland, like submandibular. The duct is going from here. There is a stone. Once the patient is eating a meal, the salivary gland will produce saliva. But the gland is obstructed by the stone. So what will happen? The gland will be distended with saliva and there will be swelling plus pain. This is typical of salivary gland duct stone, and this is known as sialolithiasis. Lithiasis means
Inflammation.
stone. Stone, S-I-A-L. Sialo means salivary gland. Polylithiasis. Poly mean gallbladder and lithiasis mean stone. Pyelolithiasis. Pyelo means kidney pelvis. Lithiasis means, so there can be stone anywhere. Lith means stone. So now this is a typical history for gallstone in the salivary gland. Clear? If the patient is just have this history, you can perform an X-ray occlusive view, and it can show you a stone in 80% of the patients, if there is. If you are not sure, then you can perform an ultrasound or CT scan or MRI scan or anything else, allography. That is the gold standard. So you can perform all these investigations to diagnose the stone. But if this picture was there and now the patient has developed fever, it has become very hot, tender, it means it is a complication of sialolithiasis. Now it has become a salivary gland abscess. So if I remind you, I told you a 65-year-old male having a diabetic foot with pus discharge has painful lymph nodes. So this is known as LYMPH, lymphadenitis. That is inflammation of the lymph node. But if this painful lymph node becomes fluctuant, tender, and the fever is more, then it can present with an abscess. Similarly, I told you a salivary gland, it can be in the beginning, it can be sialadenitis due to some viruses or bacteria, like I told you about mumps. In that case, it will be uniform and the pain will be continuous pain. It will not come and go after eating. Maybe more on eating because of the contraction of the muscles, but it will not disappear. And there will be some reason. But if it is related to the stone, the pain will be more after eating. Okay. But if sometimes the stone is not released, then it can become an abscess. So in the scenario I have given you, it was an abscess of the salivary gland. Is the point clear, or I can repeat it again?
Can you repeat, please?
Yeah, why not? So I have told you diagnosis. Number 1, SIL, sialadenitis. Then I have given you a diagnosis of sialolithiasis. Okay, 2 first. Here, take the example of mumps. Patient is having a swelling maybe unilateral or bilateral, does it disappear and reappear? No, is due to infection. So it will continue for 5 days, 7 days, 10 days, depending upon the etiology like bacteria, virus, and patient will have the local signs of inflammation like hotness, tenderness, pain, full swelling, loss of function, and systemic features like fever, tachycardia, tachypnea, and TLC count will be high. Is this point clear?
Yes.
It is, yeah, it is like pharyngitis, acute colitis, any infection. Now, if you perform the CBC of this patient, what you will find with sialadenitis?
WBC high.
Yes, the WBC count will be high. C-reactive protein will also be high. Now
Yes.
we come to
The
the sialadenitis. These are the, yes, local 5 signs and 4 systemic signs. They are in sialadenitis. Now coming to sialolithiasis. Here the patient does not have fever. There are no signs of inflammation. Here the problem is that this is suppose the gland, this is the duct of the gland going into the oral cavity, and there is a stone in the duct. Now once the patient is going to eat a meal, this will cause increased production of saliva. This saliva should reach the patient oral cavity, but due to obstruction over here, can it reach the oral cavity? No,
No.
it cannot reach there. So the gland, it will distend and it will become painful and it will distend. So the patient will tell you, doctor, after eating a meal, I have swelling of the submandibular area that is very painful, but after 2 3 hours I feel relieved. So this is a typical history of stone, and this is known as sialolithiasis. Is it clear?
Yes, doctor. Thank you very much.
Okay, just give me 1 minute. Can you see my paper book?
Yes.
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 Yes. So if you see this page, this is sialadenitis, sialadenosis. That is different, but I was talking about sialadenitis. So in the sialadenitis may be mentioned somewhere. This is sialadenitis due to HIV. This is the causative organisms for sialadenitis. Okay, so this is sialadenitis. And I told you, just remember, it is acute, but it can be chronic sometimes. So if you know the infection, if even without reading, you can make the clinical features and investigations and diagnosis by yourself. Simply, you have to remember is the inflammation. Now coming to the sialolithiasis. So this is the salivary gland stone. You can see there is a stone that can form in the gland, and the presentation is typically cyclical postprandial swelling. So we have talked about this. You can see these stone, they are removed. This is the X-ray and it is showing here the stone. Can you see the stone? This is the stone in the duct of the salivary gland, called Warden's duct. Clear? And the submandibular gland is most commonly affected 85% of the time. Saliva is alkaline, blah blah. Sometimes they ask about the saliva. This is the submultimodal gland duct stones are mainly proximal. This is the location. So there is a complication of the sialolithiasis. Sialolithiasis complicated by a secondary bacterial infection. So sialolithiasis is not an infection but stone formation. But if there is an infection in the gland, it becomes an abscess. Here you can find a stone, my cursor. Here again, there are stones in the duct. So these are the images showing you stone. And you can see here that first you need to differentiate if the say this lymph gland from the lymph node. Can anybody tell me how we can differentiate clinically the lymph node from the submandibular salivary gland?
From the
Manually.
ear.
From the
By
Ultrasound.
manual examination,
yeah. Well, how yani? So you
by
can
It
use
is
inserting two fingers in the oral and the other hand in the jaw. So I will try to palpate.
excellent.
If it's
So if you use
never,
a
if it's not palpable, it's a lymph.
very good, excellent. So you will perform a bimanual examination, one hand fingers inside the oral cavity and other hand fingers outside below the in the submandibular gland area, and you feel in between your two hands. If there is nothing, it is a lymph node, but if there is something, it is probably the salivary gland. This is the clinically, and the radiologically how you can differentiate.
Ultrasound.
by ultrasound.
Ultrasound, CT scan, MRI, you can perform anything and it will also give you the diagnosis. So this is all,
And
but the scintigraphy is the gold standard for diagnosing a stone. This is the diagnosis, but seal endoscopy. This can also not only diagnose, but it can also treat. So it can remove under local anesthesia the smaller, less than 5 millimeter distal stones, less than half centimeter stones, can be removed with endoscopy. And for the larger stones, they may require duct slitting. Anyway, you can remember few words, but sometimes we also use extracorporeal shock wave lithotripsy to break down bigger stones under ultrasound imaging, and then they can come by themselves or they can be removed by endoscopy and washing. So these are the few words about the stone of the salivary gland. So you should be able to diagnose sialolithiasis from a given scenario, and you should be able to manage the patient. So up to 5 millimeter, 5 to 7 millimeter, more than 7 millimeter, what to do. So these are the different management issues. Now coming to the tumors. So the most common tumor of the parotid gland is pleomorphic adenoma, but it can also be carcinoma. I will not take your too much time. You people will be tired. So just few words. As you know, we discussed the swelling in the beginning, and it's called etiology is T. Any swelling in the body anywhere, either it is inflammation or it is tumor or it is a trauma. In the tumor, it can be benign or malignant. From this week onward, in every week, you will have benign and malignant swelling. So please focus with me. So here, if we take the example of the salivary gland, the inflammation of the salivary gland is known as sial adenitis. Clear? If you talk about the benign swelling, suppose there is a pleomorphic adenoma and this is a carcinoma. Now, if it is a sial adenitis, history will be of 1 day, 1 week, 1 month, 1 year. What do you think? History will be how long?
1 month,
For how
1 month.
long a patient has a problem with pharyngitis or tonsillitis before he or she comes to you?
I think it's acute because the
Acute,
patient
One
cannot be
week.
swelling. Yeah,
maybe two
acute
days.
because the patient has difficulty.
Yeah, it is acute. So 2 to 3 days maximum. The patient will be with
Yeah.
you. So all the adenitis which are acute, they will develop within 2 3 years. The history will not be in months or years. Agreed?
Yeah.
Okay. The patient will present with pain or painless swelling.
Pain.
With
Pain.
pain.
Painful swelling because we have five signs of inflammation. One sign is painful. If you touch it, it will be cold or hot.
Hot.
Hot. Okay, it will be red looking or normal color of the skin.
Will be red as sign of the
Will be
inflammation.
red. Excellent. If you examine the temperature, fever will be normal or high. High. Very good. If you see the heart rate, respiratory rate, temperature, and the WBC count, it will be high. So all the itis they will depict a similar picture. But if you come to suppose a lipoma will present within 2 days, 2 months, maybe 2 years. So lipoma is a slow, a benign tumor. It may be in a patient for months or years. Patient will not come to you in days or weeks. Agreed? Because it is not growing rapidly. The swelling will be painful or painless. Usually, tumors are painful or painless in general.
Painless.
Painless. Very good. Fever or no fever?
No.
No fever. Excellent. There will be no fever. If you have the TLC count, it will be normal or high?
Normal.
Normal. So if there is a benign swelling, it will be there for years because it is very slow growing. But if it is a malignant swelling, suppose carcinoma of the breast, it will be there for 10 years? No, because it grows rapidly. So it will be there within weeks or months. Within 2 3 months, it will get very big because it is rapidly growing. So from the history, you will come to know that the swelling is inflammation, benign swelling, or malignant swelling. Am I clear? So
Yes.
you should be able to diagnose a swelling in the parotid or salivary glands. Is it benign or malignant? If it is rapidly growing, benign or malignant?
Malignant.
Okay. If it is hard, benign or malignant?
Malignant.
If it
Malignant.
is if it is soft,
Benign.
benign. Very good. Because in the heart swelling, the cells are like tightly packed. They are malignant swellings. So if it is having ulceration, involvement of the skin, then benign or malignant?
Malignant.
Malignant. If there is a nerve involvement, surrounding nerve is involved in the swelling, benign or malignant?
Malignant.
Malignant. So now you know wherever either it is thyroid salivary gland or wherever you are, if these are the features, you will decide from these features that the swelling is benign or malignant. Ulceration, surrounding nerve or structures, involvement, rapid growth, hard, all these features they suggest the swelling is malignant. But if there is a doubt, how will you confirm the diagnosis?
Biopsy?
Excellent.
Fine needle
So biopsy, which biopsy in case of the salivary glands?
Fine
fine
aspiration?
needle aspiration.
Find the aspiration cytology. It will tell you the cells are inflamed or they are benign or malignant. But if it is not sure because it
Core
takes
biopsy.
cells, then you can go for core biopsy. That takes a piece of tissue and we can look for perineural involvement. So this is how you are going to look for this malignant. And then the treatment surgery.
Doctor, one
Okay.
question, please.
Yeah, please go ahead.
What's the differences between fine needle aspiration cytology and core biopsy? Like both of them, I will take the sample from the tissue and then go to the pathologist to examine that sample. What's the differences between them?
Yeah, very good question. So the difference is F. F mean
Fine.
fine.
The size of the
Fine. So
needle.
fine mean a size of 22 or 23 G gauge needle will be taken and this needle will aspirate only cells, nothing else. Clear? And the cells will go. So its name is fine needle aspiration cytology. Cyto means cell.
Cell.
Clear? But if you want to perform a core biopsy, do you know there is a core? And what is outside the core?
Like
Coat.
the structures, yeah.
So we wear a coat above us. So we are like core, and what is outside that is coat, like white coat you wear. Clear? If you take a needle, which is this is 20. If suppose it is a 12 gauge needle. Now this is a wider needle. Now it will not take cells, it will take a piece of tissue itself which has cell and surrounding structures. Because only seeing the cells, it may not differentiate between benign and malignant swelling. But a tissue containing the cell and intracellular tissue where there is the lymphatics, there are the nerves, there are the blood vessels. This tissue, so it contains tissue. Now we are able to see in between the cells as well. So this tissue will be required to differentiate. So this is known as core biopsy. If you remove the whole lesion, then you call it axion biopsy. If you remove a piece of the lesion, then you call it incision biopsy. So
Yeah,
there is different kinds, but what about core and fine? Did you understand?
I got it, doctor. But like, sometimes the needle aspiration it's not enough to take the structure around the cell, but core biopsy it will take more structures or more tissue.
Yeah.
Okay, why we don't skip the needle aspirations? Because there is risk damage to the other structure by the core biopsy.
Ah, yeah. Core biopsy can be damaging.
Okay, I got it.
Core
Yes.
biopsy, yeah. Like in thyroid, suppose, or even the salivary, in every patient, if you go, you will do overdo. So if we do not go for core biopsy in the beginning because the needle size is big and it can cause tissue damage. There are the nerves and other structures and there is a vascularity. So there may be a lot of bleeding as well. So this is the reason, depending upon the
Yeah.
organ. Okay, now if it is a benign or malignant swelling, just few complications. In case of parotid gland, because you are dealing with a gland which is forming saliva. If the saliva collects, this is known as yellow seal, a complication. Then they're going to be bleeding, hematoma, blah, 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 infection. But I will come to the specific complications. Other you can see in the book. One of them is the injury to the great auricular nerve. That can cause loss at the ear lobe, especially in the females who are wearing different earpieces, studs, there may be a problem. So this can be one. Then we have the facial nerve, which is going through the nerve, through the gland with its five branches. So this nerve can be damaged. So you should know the facial nerve, its branches, and how to assess. In your exam, suppose the patient is having a surgery, and if you ask him to look up, she can look up without furrowing, or if I blow her face, or there is any, I will describe the injury. I will not say facial nerve is damaged. So your duty is to know from the examination that there is a damage to the facial nerve. So this nerve passes through the parotid gland, so it can be damaged. And third is the what you call it, the Frey syndrome. So in the Frey syndrome, what happens? The autonomic nervous system, the sympathetic supply to the gland, parasympathetic nerve supply, that is now connected to the sweat gland. So once the patient eats, normally it causes saliva production. But in a patient with Frey syndrome, it will cause, instead of saliva, sweating over that part. So this is known as Frey syndrome, and we have a starch iodine test. If we apply to the starch iodine to the patient's face, if its color turns to blue, then it means the saliva is the sweat is secreted, so test is positive. Actually, it should be prevented, but if it happens at all, then there are many treatments, but the best is botulinum toxin injection. There are others there, but at least see this Frey syndrome. I will not take too much time because we have to finish. Then coming to the submandibular gland, same problems, but if you go for surgery, the consequences are damage to the hypoglossal nerve. So we will say, while we ask the patient to show his tongue, to bring it out, the tongue deviates to the left or right. It indicates indication the damage to the hypoglossal nerve, which is responsible for movements of the tongue. Other nerve damage, which is the lingual nerve. This is a sensory nerve related to the taste. And the last nerve which is damaged is the mandible, this fourth branch of the facial nerve, which can cause deviation of the angle of mouth. Cervical mandibular branch. So these are the three nerves which can be damaged in the nerve surgery to the submandibular salivary gland. So these are important. Other things are also important, but these are the three nerves. Last year there was a patient, and his one nerve was damaged, and I think it was the hypoglossal nerve that was damaged in the King Fahad. So once we examined that patient, we diagnosed, and the patient got worried. Whenever you see any complication or anything, please do not disclose anything to the patient. We are not supposed to talk or disclose. We can just take history or do physical examination, except DRE and other examination. So these are few words about the salivary gland. Just to close, because we have to finish. Do you want to hear melanoma or keep it for Tuesday?
If you don't mind, can you just tell the important things?
Okay, why not? So as you know, the melanocytes. They are in the epidermal layer, and their tumor is melanoma. Remember, one thing is A, B, C, D, E. If the existing nevus, it becomes asymmetrical, or its border changes, or the color changes, or the diameter is more than 6 millimeter, or it is elevated. These are the signs or there is suppose irritation, discharge, ulceration. These are the signs indicating that a benign tumor has become malignant. Clear? Number one. Number two, there are certain types. Just remember a superficial spreading. Its name is superficial spreading. So if it is the skin, it will skin like this. So these are forming like 70% of the tumors. Nodular variety. These are spreading like this, but they spread like this. So this variety is very dangerous because you know the neurovascular bundles are lying here in between the papillary and reticular layer. Once these structures are involved, the melanoma will spread to the surrounding organs of the whole body. So the nodular variety is very, very uh, dangerous. But luckily, it is like 30%, 20 to 30%. The other two are one is known as lentigo maligna melanoma. This is in the previous, if you know, there is a condition called lentigo maligna. This is usually the benign condition which has a potential of pre-malignant, sorry, it is pre-malignant. So this may become malignant and this is existing nevi. And the fourth condition is known as acral. You can remember the word acral from acro. Do you know what is acro? Acromegaly. Anybody remembers acromegaly, acrobat? Acro means related to the digit, the limbs, like hand, feet. So if the melanoma is on the sole of the hand or palm of the feet, they are known as acral malignant melanoma. But if it is under the nail, then subungular it is superficial spreading. And the last fifth variety is amelanotic. Amelanotic means there is no color. So these are the five varieties. Just last point, we use the T and M classification to stage it. T means tumor, N means lymph node, M means metastasis. If the tumor is less than 1 millimeter, then it is T1. 1.01 to 2 millimeter, it is T2. 2 to 4 millimeter, T3. And T4 is more than 4 millimeters. So this is how you see the T. There is another classification for the tumor that is known as Brodder's thickness. There is another called Clark. Anyway, Brodder's is important because it may be asked in your exam. So you should know that the T means tumor itself. If the tumor cells go to the lymph node, this is known as LN lymph node tumor N here, and M is for Mets. So if there is one lymph node, this is N1. If there is 2 to 3 lymph nodes, so it is like this. So if the tumor is either T1, T2, whatever, but if the N is 0, either it is stage 1 or stage 2. But once the lymph node is involved, it becomes stage 3. And once there is METS, this is stage 4. The treatment is surgical, especially for stage 1 and 2. If there is a stage 3, then along with surgical, you will give him the systemic chemotherapy. Clear? Because once the lymph node become involved, you give them systemic treatment. It will be chemotherapy, it will be the specific monoclonal antibodies and other treatment options. If it is stage 4, then it is basically the systemic treatment. Local treatment is not as effective. So this is a very few words, but at least you know what when to give systemic treatment, new adjuvant treatment, the systemic treatment. So this is the few words about the melanoma. Remember the patients at risk, other than family history and other things. Remember A, B, C, D, etc. Then different types. Diagnosis. Diagnosis is always by excision biopsy, except if it is on the face or very big. And the tumor-free margin should be 2 to 3 millimeter. Inshallah, tomorrow on Tuesday, we will discuss it in more detail. In the management, treatment is surgical. But once the lymph nodes are involved, include the systemic treatment. So this is the summary of the melanoma. If you have any questions, you are welcome.
Doctor,
Yes, please.
in the salivary gland stone or يعني submandibular stone, when we can use يعني CT or MRI يعني يعني first we should start by the ultrasound or يعني by manual examination then ultrasound. If ultrasound يعني was not clear,
If you
go
see
to
here, yeah, if you see the conventional radiographs, they are considered as an initial diagnostic test if you are sure it is a stone. If you think it is not a stone or you are not sure, you can start with an ultrasound to see it is a lymph node or something else, to see which organ is involved. But if you think it is a stone, you can order an occlusive view showing the stone, this X-ray, clear?
okay, and
But 80% of the stones are radio opaque. Now, what to do about 20% of the stones?
so X-ray will
So you
show.
go for CT scan. Only out of 100 patients, 80 patient stones will be visible like this on the X-ray. 20 patients stones is not visible. For these patients, you can use CT scan or ultrasonography or MRI. And if there is still doubt, you can perform cyalography. It means you can put a contrast material in the patient duct. And cyal endoscopy is means you put a camera inside the duct. This will be diagnostic and therapeutic, and you can see the pictures ahead. I think behind. Yes, these are the pictures, different pictures showing. This is cyal endoscopy. Cyal endoscopic stricture dilatation. So anyway, you can use these investigations as required. But 80% of the patients, they can be diagnosed by X-ray mouth.
Okay. يعني X-ray is the initial
Yes.
initial investigation.
If required, you can go for ultrasound or CT or MRI. But the gold standard is, the best is cyalography. It means putting a contrast material.
Okay. Thank you.
Thank you very much, all of you. God bless you.
Thank you so much, Doctor.